Hello, future nurses. Quick content review for Unit 9. It covers 2 chapters, the first being Chapter 23, Eating and Sleeping Disorders. So eating disorders are disturbance in behaviors associated with ingestion of food. 30% of all adults believe their current weight is greater than what their weight should be. Positive body images lead to behaviors that express confidence and self-assurance, while negative body images can lead to problems such as shyness and social isolation. I'm going to flip over to the book while we're going through some of these, but Table 23.1 is a good table to look at to discuss types of eating disorders. So anorexia nervosa. Anorexia nervosa is where the individual cannot maintain a normal body weight because of an intense fear of becoming fat. 90 to 95% of people with anorexia nervosa are female, while most of them are teenagers. These are disorders that start in the teenage years. You usually see a tense, overbearing parent, and this is a way for the child to control their behavior. An individual with anorexia, if we were to look at a classic description, tense, alert, hyperactive, rigid, and female. You can also see lanugo, and that's that light, feathery skin that you often see in newborns. And individuals with anorexia will have that because they have no body fat. They can't control their temperature, so they're intolerant to cold. So in the client with anorexia, the smallest weight gain is seen as a threat and a failure of self-control. They go to great measures to monitor their body, such as weighing themselves multiple times a day, measuring their body parts, continuously looking in the mirror to make sure they're fat. So the criteria to be diagnosed with this: refusal to maintain a body weight greater than 15% below normal. Even though they're underweight, they have an intense fear of becoming fat. Distorted significance placed on body weight and shape, and an absence of at least 3 menstrual cycles in a female who has previously menstruated. Right? That's called amenorrhea. So anorexia has a high mortality rate due to complications from starvation, cardiac arrest, and suicide. The death rate associated with anorexia is higher than any other mental disorder. Because there's that tense anxiety and fear of gaining weight, you see a lot of other mental illness that goes hand in hand with it: anxiety, borderline personality, and depression. So I will not play it, but we watched this in class. This is To the Bone. Lily Collins did a really good job I think, of portraying what is an eating disorder. She's, pushing food around the plate. She's exercising completely. There's that family parent influence and struggle. That's in it. She, and the doctor calls her out on it, Lily, even in the trailer. She's, doing so many sit-ups that her spine is bruised. So we want to make sure we're interrupting patients when they're exercising or, doing 100 push-ups a day, especially one with anorexia. The refeeding syndrome occurs when we have someone who's severely anorexic and they're going to resume eating. Complications such as heart failure and death can occur in individuals who had no or little nutritional intake for a period of time. So what happens is there's low potassium in the blood, and that's the most common electrolyte problem observed in these serious eating disorders, especially in patients who purge and use laxatives or diuretics. Because potassium is the major electrolyte in most of our cells, and it is vital for nerve and muscular cellular functioning, particularly for cardiac functioning, you need adequate potassium to help your heartbeat and to keep it in a normal rhythm. Anorexia and bulimia lead to low potassium, which can cause weakness, muscles, cramps, seizures, paralysis, confusion, respiratory failure, constipation, impaired kidney function, and death, along with irregular heartbeat, low blood pressure, cardiac arrest. So you really, really, really have to be mindful of hypokalemia, because of the fact that hypokalemia can kill these patients. Right? We always need to be mindful of what are our normal lab values. And y'all should be familiar with the normal value of potassium. So bulimia is binging and purging. It's a cycle. They binge eat, self-induced vomiting, binge eat, self-induced vomiting. Often found young upper, white, middle class, and upper class women. And this is through perfectionism. these patients are going to have a lot of shame. They're going to be hiding these behaviors from everyone. It's not anything that they want out or known that they're doing it. Individuals with bulimia often go untreated. While anorexia, you can clearly see that someone is way below body weight. Individuals with bulimia are often a normal body weight. And there's that high mortality rate because of those changes in electrolytes from that binging and purging. So binge eating disorder, right? My 600-pound life. Recurrent episodes of eating excessive amounts of food in a short period, at least once a week for 3 months. And they're not compensating for it by purging or excessive exercise. So in bulimia, they are purging on food, so they're eating excessive amounts to the point where they're not hungry anymore, where they're full, where they feel sick, they've eaten so much. And then they're going to compensate with it by purging. In binge eating disorder, they're going to eat rapidly. They're going to eat when they're not hungry. They're going to feel shame and guilt too. But they're not compensating for the excess eating. So obesity is an excess of body weight. It results from too many calories consumed or not enough calories burnt. It has not been established that obesity on its own is associated with any mental health or behavioral problems. We see obesity often in early life, and it can go with compulsive overeating, just like that binge eating disorder. But obesity can also just happen just because. Other eating disorders to be mindful of are pica. It's persistent eating of non-food items. Clay, laundry starch, insects. Usually there's some type of malnutrition going on, and pica's a way of the body. It's craving, iron, and it's going to eat something else to try to get the iron from the dirt. Rumination disorders, regurgitating and rechewing of food. So you eat some food, you spit it back up again, kind of like that mama baby bird, and then you rechew and eat it again. Things we need to keep in mind with these patients: guidelines for intervention. Establish the health of the client, right? We're focused on Maslow. We want them to eat. We want to stabilize medical problems, get normal nutrition and eating patterns down, and then last, resolve emotional issues that underlie the eating disorder. If we're afraid our patient's going to die, we cannot get to the underlying reasons for it. One of the things we can do to help is antidepressants, right? Antidepressants, especially SSRIs, are first line for almost everything. And a lot of times in anorexia and bulimia and some of the other eating disorders, there is a depression, there is an anxiety that goes with it. So antidepressants are a nice, good, safe line. But the first thing we want to do is stabilize medical problems and get the patient eating. We want to assist the client to identify how food is used to provide comfort and reduce anxiety, right? Help them to replace that distorted body image with a good one. And we want to teach problem-solving skills. We know when what we're doing with the client is effective when we see healthy eating choices in individuals who engage in eating. So if you have an individual with anorexia, them engaging in any eating at all, right, that is a positive outcome. So we need to focus first on establishing those good habits and then work on the reasons behind it. So we covered a lot, and I want to go through your book with you before we go to sleeping disorders. So eating disorders, table 23.1 talks about different types of eating disorders. And you can see some differences. Anorexia athletica, excessive exercise. Right? Well, anorexia nervosa is less, they're not eating. Binge eating disorder, bulimia, I can't even say it. Dialbulimia, they're controlling insulin. Orthorexia nervosa, I'm sure we all can think of some people with that, eating pure, right, proper foods. So it's going to kind of come down through a lot of it. When you see anorexia, we kind of talked about it in class, and this is a really good picture. This is what an individual with anorexia might look like to us. But when they look in the mirror, they're going to see this picture, and they're going to see, like, think almost like an hallucination. They're going to see themselves bigger than what they actually are. This table is good to know. Students often mix up anorexia and bulimia, and it will kind of space down what you can see between the two. to know it. Anorexia, they're not really going to use vomiting, diuretics, or laxatives. It has the most severe weight loss, and they're just kind of going to starve themselves. Right? Bulimia, they're going to be hungry. They're going to use diuretics and laxatives because they're trying to compensate for it. Let's see. There's a good little case study here. Okay, switch back to sleep. Give me 1 second. Okay, so sleeping disorders, this is the second half of chapter 23, right? Normal sleep. Body functions and everything slows down. We are conserving energy. We're relaxing. Our cells are repairing ourselves. Dreams happen, especially during your REM sleep. And then you have 4 stages of sleep. You have non-REM stage 1, non-REM stage 2, non-REM stage 3, and REM sleep. And your body's going to progress through those stages, usually in a pattern throughout the night. You get more stage 3 sleep later in the evening, earlier in the morning, however you want to say it, towards the end of sleep. And REM stage 1 usually doesn't happen unless you wake up in the middle of the night. This is that transition stage between sleep and wakefulness. And they're going to rotate throughout the night. We watched this TED Talk, at least some of it, on sleeping disorders. So what do you see? A sleep disorder is a condition or problem that disrupts an individual's pattern of sleep. History and physical exam findings are honestly the most common. Several tests can be done, and those are more so for your extreme, when we're talking sleep apnea, narcolepsy, that we're going to see some of these used. So as we talk about sleep disorders, we're going to talk about dysomnias. They affect falling asleep and or staying asleep, and parasomnias, which are sleepwalking night terrors. Which sleep do you need? We know as adults we need 7 to 9 hours of sleep tonight. I don't know about y'all. I know there's one of you who are getting it. I am not getting 7 hours of sleep at night. But that's our goal. That's where we should be getting, right? Newborns are going to get 14 to 17, 5 to 10, 10 to 11. And the amount of sleep as we get older is going to decrease. So dysomnias. Insomnia, difficulty falling or maintaining sleep. Hypersomnia, right? Hyper, extra, a lot. Excessive sleepiness. This is someone who was normally had no issues maybe with sleep, and then all of a sudden, no matter what they do, they're just absolutely exhausted. They could sleep 12 hours at night and they still wake up physically incapable of doing anything. Narcolepsy, repeated attacks of sleep, right? You're sitting up and all of a sudden you just pass out and fall asleep. Cataplexy is that sudden episode of muscle weakness, loss of muscle tone, right? That's that person in narcolepsy, when they fall asleep, all of their muscle goes with it. They kind of just collapse. And they have inappropriate rapid eye movement. Well, when we fall asleep normally at night, are going to go through stage 1, 2, 3, and then into rapid eye movement. In narcolepsy, you kind of just jump straight to rapid eye movement. Dreamlike hallucinations can happen in that during narcolepsy because that's right, rapid eye movements when we have most of our dreams. We watched this video on hypersomnia. The individuals struggle with work and jobs because they're always just so tired no matter what they do. Some more dysomnias, obstructive sleep apnea, right? That's breathing, a breathing related sleep disorder. Periods of apnea, so stop breathing, that waken the individual. And they might not notice that they're waking up at night, but they have really disorganized speech. They're really tired in the morning. And usually, right, you're going to have the partner complaining. It's going to be the wife, the spouse, the significant other, who's going to be like, look, this guy, and it usually is males, middle-aged males who are obese and like to drink alcohol. Those are some of your common risk factors. They're snoring all night long. You can hear them stop breathing. Circadian rhythm sleep disorder. This is night shift, right? Your sleep pattern, your personal body rhythm, what you need to sleep doesn't match up to your environmental demands. You would like to go to bed every night at 9 or 10 o'clock. However, you don't get off of work until 3 in the morning, or you don't get off of work until 7 a.m. and you stay up all night because you work night shift. Restless leg syndrome. Restless leg syndrome always killed me because I always, when I first started hearing about it, because we didn't learn this in nursing school, I thought it was like your legs don't stop moving. However, restless leg syndrome is often more sensations, prickling, tingling, itching, crawling sensations that occur while a person's falling asleep or staying asleep. So for dysomnias, right, we had the last slide. So dysomnias are your insomnia, primary hypersomnia, narcolepsy, obstructive sleep apnea, that's your breathing-related sleep disorder, circadian rhythm sleep disorder, you work night shift, and restless leg syndrome, those sensations in the leg. We watched this video with Tom on what is sleep apnea. So your parasomnias, right? Parasomnias are nightmares. They're sleepwalking, right? So nightmare disorder, repeated frightening dreams that lead you to wake up at night. Sleep terrors, repeated nightmares and abrupt awakenings accompanied by panicky cry, screams, intense fear. These, you see sleep terrors a lot in kids, and they often don't know that it's happening, and sometimes they wake up screaming and then they fall right back asleep. Sleepwalking disorder, I always think of Frankenstein. You're doing complex things while you're asleep. Blank stare, walking around, but you're mentally asleep. You're physically gone. You're just moving around. Other sleep-related disorders, nocturnal sleep-related eating disorder. This is binging during sleep, even non-food items. It could be, sleep disorders can also come from physical problems, right? If you're sick and you have pneumonia and you're up coughing all night, right? You could be coughing and it keeps you from sleeping. Many mental health disorders are associated with sleep problems. Generalized anxiety disorder, you're so anxious you're sitting there worrying all night. PTSD, flashback and nightmares, right? Depression, you're too tired and depressed to sleep. Sleep problems during substance use and or periods of withdrawal, right? Stimulants, my favorite, methamphetamines. You take enough methamphetamines, nothing's going to put you to sleep and you'll be awake for a week. So what do we got to do? We got to teach our patients sleep hygiene, right? The main goal of care is to assist the client in obtaining a restful night of sleep. Bright light therapy in the morning, being exposed to the sun, helps reestablish body rhythm. We want a cool, dark room. Don't exercise right before bed. Don't eat a big meal right before bed, right? Promote comfort. Go to bed, wake up at the same time. Quiet environment. What are physical disturbances? 23.5 in your book, box 23.5 is a good one to take a look at. So before we pop over to our sexual disorders, right, we got our table that goes over our need for sleep. Anything that's ever in a table is always something, or a figure in your book is always good to know, right? So sleep disorders at our secondary and our primary sleep disorders are related into dysomnias and parasomnias. So right, again, your dysomnias, insomnia, hypersomnia, narcolepsy, breathing-related sleep disorder, and our breathing-related sleep disorder is sleep apnea, circadian rhythm sleep disorder, and then your parasomnias, nightmare, sleep terrors, sleepwalking, and sleep-related movement disorders. And then 23.5 shows what is good sleep hygiene. Right, regular bedtime, comfortable bed, warm bath before bed, cool temperature in the room. Right, you don't want to be too hungry, but you don't want to eat a large meal before bed, and you don't want to work out right before bed because it just keeps waking you up at night. Okay, we are going to move on now to sexual disorders. There is a lot in all of this information, y'all. Okay, sexual disorders, continuum of sexual responses, right? Adaptive, behaviors that respects the rights and wishes of others. Maladaptive, harmful to yourself or harmful to others in some way. There is a continuum, right? Usual healthy sex is between two consenting adults. It is satisfying to both. It is not forced or coerced, and it's conducted in privacy. Some sexual behavior that even is normal can produce anxiety for individuals, right? We have a lot of sexual dysfunctions. The far end, the negative end, might involve minors, violence, force, or even as simple as just a lack of consent. This is a maladaptive sexual behavior. We have to be aware about our self-awareness and sexuality, especially as healthcare providers. Y'all need to continuously be assessing yourself and how are you going to interact with these patients? Where are your values, right? If you have a patient, they're telling you something and it might be, healthy, right? One of my preceptors when I was in nursing school was a dominatrix in a dungeon. And she was talking about how she earned all her money and then some in nursing school by being a dominatrix, right? That was appropriate. It's legal. She was able to do it. We need to deal with our expressions and our faces, all of it, if the patient starts telling you this stuff. Sexuality begins at birth and ends in death. Ugh, I'm hitting buttons that I should not be hitting. I apologize, y'all. Okay, so children, right? Twin 3-year-olds kind of can start to tell who's a boy and who's a girl. At school age, they start to associate with the same gender patient. Adolescents, right? Really hard time, right? Dating is expected to be normal, right? Adolescents, we understand kind of what sex is and we start to become sexually active and branch out. Adulthood, usually in our society, relative monogamy, appears to be the norm. Depending on what is going on with our life, our sexual behaviors may change, right? Sexuality patterns of middle-aged adults have changed recently. More women in their 30s and 40s are bearing children and starting families. Well, it used to be 19, 20, early 20s you were having a kid. We're now pushing it. And single parenthood is a lot more common. In the older adult, we cannot forget that old people still want to have sex, right? They can still be just as interested in it as younger adults. And especially if you're working in a nursing home or another facility for older adults, we have to understand that that's going to be a concern that they have, and we need to make sure we're talking about it with them and assessing them. Sexuality and disability. Many individuals with a permanent disability can have rich, satisfying sexual lives with some adaptation, right? To improve their quality of life, it involves changing social attitudes that limit the disabled population. There is no reason a person with a hip replacement cannot have a healthy sex life. The modes of sexual expression. Sexual attraction, who you're sexually attracted to, your sexual orientation. Your sexual orientation is who you are romantically attracted to, right? And it could be a specific gender. Heterosexuality, you are expressing your sexuality with members of the opposite gender. Homosexuality, preference for one's own gender. And then, I gotta fix this, asexual relationships should almost be separate. You could just not be sexual. Bisexuality, attracted to and engaged in sexual activities with both genders. Transgender, right? Whatever gender you were assigned at birth, your gender expression or behavior doesn't conform to that. So someone who is born biologically female, their gender expression, their gender identity is that of a male, right? They may dress as a male. They may go through hormone therapy and surgery. It's going to be up to that each individual. Transvestitism is also known as cross-dressing. And we got to remember, not all transvestites are homosexual. Most are like older white men who are married to someone of the opposite sex. They just really like wearing lace panties. Modes of sexual expression, right? Biologically, chromosomes and genetics. Psychoanalytical, that's Freud and some of his crazy talk. Behavioral theories, what you learn around you, right? Females learn primary female roles because that's what we see. A child who's raised, and was sexually abused and exposed to porn at a young age, that is what they learn. Psychosocial disorders. These fall into two different types. Table 29.3 in your book covers a lot of them, and we'll flip through and look at your book too. So sexual disorders, problems that cause distress and impaired functioning in an individual who are exposed to sexual behavior. Sexual dysfunction, something happens there's 4 stages of sexual excitement and pleasure: appetite, excitement, orgasm, resolution. Sexual dysfunction is something happens during one of those stages, right? So erectile dysfunction, can't obtain or maintain an erection, genitopelvic pain or penetration disorder, pain and anxiety associated with sexual intercourse. A lot of those are associated with it, and those are in your book, table 29.3. Psychosocial disorders, gender dysphoria. Children with gender dysphoria are unhappy with their own sexuality. There's an intense dislike for their sexual anatomy. The number of people who transition, many of the people may transition into their desired gender. A lot of times when we see gender dysphoria, the child or even the adult may dress like the opposite gender. Psychosocial disorders. This is box 29.2. These are a lot of your isms and ilias. So paraphilias, sexual variations that are not in line with society's norms, right? Pedophilia, exhibitionist, fetishism, I can never say these, voyeurism. We watched that short little video. Sexual addiction. This is often overused. It's progressive and chronic, and you need more and more and more sex to get off, to relieve the emotional pain. It's going to impair work and social relationships because of it. Now, not every guy who says that that's why they were cheating on you because they had a sex addiction, they probably don't have a sex addiction. But it is possible. There are people out there, right? And this leads to loss of family, loss of work, social relationships, poor job performances. So therapeutic interventions. Depending on the cause and the symptoms, we can treat it. All sorts of meds for erectile dysfunction out there. Behavioral therapy, positive reinforcement, aversive therapy, hormonal drug therapy. If someone's struggling with gender dysphoria, and they want to transition to the opposite sex, we can do hormones. Environmental control or incarceration. Maladaptive sexual practices, right? So if we're going against the needs and wills of others, you can be incarcerated for that. Psychosocial assessment. Be aware of the client's function, comfort when assessing. We need to look at what each client's problem is, and we need to assess, right? We have to be non-judgmental when assessing. We need to demonstrate respect for the private content of the issue being discussed and encourage elaboration. I heard you say this. Is this what you mean? Reflect back and ensure we understand what the concern is. We never want to offer false reassurances. And we also never just want to say, oh, okay. And we must assess our own views, I feel like I've said this before, on sexuality before caring for these clients. Education, lots of education. Prevention of HIV and AIDS, prevention of other STDs, how to not get pregnant, right? What are the various means of sexual expression? That is it, y'all. Let's flip real quick to chapter 29. That's that sexual disorder chapter, right? Remember, if anything's ever in a table, those are really good things to look at. Here are some of those terms that we talk about, right? Intersex, we didn't really even talk about that. Don't meet the medical definition of male or female at birth. It used to be called a hermaphrodite, and we've changed the term over the years to intersex. So here are sexual, right? What is heterosexuality, transgender, transvestitism? Okay. Classifications of sexual dysfunctions. Aversion disorder, you just don't like sex. Female sexual arousal, right? The female just cannot get aroused. Male erectile disorder, probably the most common one. You just can't get it up. Female male orgasmic disorder, there's a delay or absence of an orgasm. It just can't happen. Premature ejaculation, right? That very first time doesn't take much stimulation and all of a sudden it's over. Delayed, right? Is it infrequent? Is it absence? Does it just take forever? Genitopelvic pain penetration disorder, you see more in, this is a female, pain or anxiety associated with sexual intercourse. Tightening of the pelvic floor muscles. Sexual dysfunction caused by a medical condition, right? There could be something wrong. Substance induced, caused by a substance. These are all your philias that we've talked about. My kids just walked in, so I am not going to be reading these out loud. Most of them, y'all have probably heard of them before. Just be aware of the more common ones and the basics. And your signs of sexual addiction. If y'all have any questions going into exam 4 or with this topic, please reach out and let me know.